we're going to explore a critical and timely topic: opioids, their uses, how they can be misused, and the far-reaching impact they have on our society. This presentation will cover everything from the medical applications and pharmacology of opioids to the risks involved and the consequences we face as a community. As you can see in the image, this subject touches the lives of both healthcare professionals and patients alike, highlighting its importance for us all. Let's dive in and gain a deeper understanding of this complex issue. Pain is a deeply personal experience, which makes it challenging to measure objectively. This subjectivity is a key reason why using opioids in clinical care is so complex. Opioids work in several important ways. They block pain signals at the spinal cord level, activate the brain and central nervous system's pain suppression systems, and also change how we perceive and emotionally respond to pain. Understanding these mechanisms is crucial, as it helps explain both the potential benefits and the risks involved in opioid use for managing pain. Here we see a brief history of opium and opioids, beginning with ancient times. Opium has been used as a pain reliever for at least 3,500 years, and evidence shows that the opium poppy was cultivated as far back as 10,000 years ago. Moving into the 19th century, there were significant advances. In 1806, morphine was isolated from opium, and then in 1857, the hypodermic needle was invented, enabling direct administration of opioids and changing medical practice profoundly. By the early 20th century, concerns about addiction led to important regulations. The Pure Food and Drug Act of 1906 required ingredient labeling on medications, and shortly after, the 1914 Harrison Narcotics Act restricted prescriptions of narcotics. These milestones highlight how opioid use and control have evolved, reflecting both medical progress and public health challenges. The image here, showing an old handwritten document alongside leather-bound books, ties us visually to these historical moments. Here we have the classification of opioid compounds divided into three main categories. First, natural opiates, which are directly obtained from the opium poppy. Notable examples include morphine and codeine. Next, semisynthetic opiates are chemically altered derivatives of these natural opiates. Heroin and hydrocodone fall into this group, combining natural sources with chemical modification. Finally, synthetic opioids are completely synthesized in laboratories and do not come from the poppy. Fentanyl and methadone are key examples here. Understanding these categories helps us grasp the origins and differences among opioids, which is essential for their medical application and usage. Here we see the main medical applications of opioids illustrated by their approximate prescription proportions. The largest category, making up about 60% of opioid prescriptions, is acute pain management. This is because opioids are highly effective for short-term pain relief, such as after surgery or injury. Chronic pain management accounts for around 30% of prescriptions, though this use is more controversial due to the risks of long-term opioid therapy, including dependency and side effects. Finally, about 10% of opioid prescriptions are for other uses like cough suppression and severe diarrhea control, which are less common but still important clinical applications. This bar chart clearly shows how opioids are primarily prescribed for acute pain, with smaller but significant roles in chronic pain and other medical conditions. Here, we have an overview of 6 common opioid medications along with their key properties. Starting with morphine, which is considered the gold standard in opioid analgesics. It's taken orally but undergoes significant first-pass metabolism, so its onset is around 20 to 30 minutes, lasting up to 7 hours. Common side effects include respiratory depression and constipation. Next is fentanyl, a synthetic opioid that's 10 to 50 times more potent than morphine. It acts very quickly, especially when given intravenously, though patches have a slower onset. One major concern with fentanyl is its risk of causing prolonged respiratory depression that can outlast its analgesic effects. Methadone comes after that. It's used for long-term pain relief and has a variable, often long half-life, which means it requires careful dosing to avoid accumulation. Methadone also carries a risk of cardiac arrhythmias and can interact with many other medications. Oxycodone, commonly known as OxyContin in its controlled-release form, is a synthetic opioid for moderate to severe pain. Its time-release formulation peaks in under an hour and helps maintain steady pain control, but unfortunately, it's widely misused due to its availability and effects. Buprenorphine is a partial mu receptor agonist, roughly 30 times as potent as morphine, with a notably long half-life of up to 37 hours. It has a safer profile compared to full agonists and is frequently used in the treatment of opioid use disorder. Finally, codeine is a natural opiate prodrug that the body partially converts into morphine. It provides mild analgesia for mild to moderate pain and can suppress cough. However, its metabolism is highly variable between individuals, which affects both its potency and toxicity. This slide paints a comprehensive picture of these opioids, illustrating their differences in potency, duration, and safety, with morphine standing as the benchmark against which the others are compared. Here we focus on how opioids work by targeting specific receptors in the brain and central nervous system. Opioids bind primarily to three types of receptors: mu, kappa, and delta. These receptors normally respond to natural peptides like endorphins and enkephalins, which help regulate pain and mood. When opioids activate these receptors, they produce effects such as pain relief and sedation. The mu receptor, in particular, plays a key role in stimulating the brain's dopamine pathways, which is why opioids can create feelings of reward and euphoria, but also why they carry a high risk for addiction. The image here shows a doctor explaining brain scans to a patient, highlighting the clinical importance of understanding these neurochemical interactions. The table summarizes each receptor type and its main functions in the nervous system, helping us see how different opioids might produce varied effects depending on which receptors they target. This knowledge is essential for both effective pain management and addressing the challenges of opioid misuse. When we look at the benefits of opioids, they stand out as powerful tools for managing acute pain. They provide rapid and effective pain relief, especially following injury or surgery, which can significantly improve recovery and enhance palliative care. The intravenous and intramuscular routes are particularly valuable because they allow for fast onset of pain control, which is crucial in many clinical situations. On the other hand, it's important to be mindful of the risks associated with opioid use. One of the most serious concerns is dose-related respiratory depression, which can be life-threatening if not carefully managed. Constipation is another common side effect that often persists, causing ongoing discomfort. Methadone, in particular, carries additional cardiac risks like QT interval prolongation. Patients may also experience sedation and cognitive impairment, which can affect their daily functioning. Lastly, although uncommon, there is a risk of physician-induced addiction when opioids are not prescribed responsibly. This comparison underscores the critical need for a balanced, informed approach in opioid prescribing, aiming to maximize their undeniable benefits while minimizing potential harms. Here, we're looking at how the body adjusts to opioids through neuroadaptation and the development of tolerance. Neuroadaptation begins very quickly after the first use, and some people develop tolerance within just days or weeks. This tolerance mainly affects the pain-relieving effects of opioids, but it doesn't impact all their effects equally. Next, let's talk about withdrawal. Withdrawal happens in two main phases. The acute phase peaks within a few days and can last about a week, depending on the type of opioid. Then there's an extended phase, which can continue for weeks or even months, with symptoms that vary in intensity. The severity and duration of withdrawal symptoms are influenced by the specific opioid involved as well as individual factors. Understanding these processes helps us distinguish between tolerance, withdrawal, and concepts like pseudo-addiction, where increased opioid use may actually be due to unmanaged pain rather than addiction itself. This knowledge is crucial for planning effective treatment and providing the right support during recovery. Here, we explore some emerging alternatives and peripheral mu opioid receptor antagonists in pain management. First, ziconotide is a powerful analgesic derived from marine snail venom. It's delivered through an implanted pump for patients with persistent pain. While effective, it requires close monitoring due to possible neurological side effects. Then we have drugs like methylnaltrexone, alvimipan, and naloxegol. These compounds specifically target peripheral mu opioid receptors to relieve opioid-induced constipation, but importantly, they do not interfere with the central pain relief effects of opioids. This represents a significant advancement in addressing some of the common side effects associated with opioid use. The image of the capsule here reminds us of the pharmaceutical innovations involved in these treatments. Overall, these options mark promising steps forward in managing pain while minimizing adverse effects. Here we see a clear and concerning trend in opioid misuse worldwide. The number of opioid users has nearly doubled from 31 million in 2010 to 62 million by 2019. This rapid increase highlights how widespread the issue has become. One of the key factors driving this surge is the large portion of prescription opioids that are diverted for non-medical use. Additionally, we've seen a dramatic rise in the presence of fentanyl and its analogs, which are much more potent and have significantly contributed to the rise in overdose deaths. Another important point is the shifting demographics. Opioid misuse is increasingly affecting younger adults and those living in suburban areas, not just traditional urban centers. Understanding these patterns is crucial as it frames the evolving and complex challenges we face in addressing opioid misuse globally. Here, we take a closer look at some of the opioids that are most commonly misused. This list includes substances like heroin, fentanyl, oxycodone or OxyContin, hydromorphone, buprenorphine, and codeine. Each of these varies in potency and how they are typically used medically, but they all share a high potential for misuse. Now, when it comes to how these opioids are misused, there are several methods. People might take them orally, snort them, known as insufflation, smoke them, often referred to as chasing the dragon, or inject them either under the skin, called skin popping, or directly into the veins. The method chosen significantly impacts how fast the drug takes effect and the overall risk of an overdose. Understanding these methods is essential in grasping the complexities of opioid misuse and its dangers. On this slide, we see the primary sources of illicit opioid supply presented as a horizontal bar chart. The most significant source, making up 76%, is diversion from prescriptions originally prescribed to others. This means that a large portion of opioids being misused are obtained not from one's own prescription, but from someone else's medication. Next, 20% of diverted opioids come from individuals misusing their own prescriptions. Lastly, a smaller 4% comes from other means like illicit supply, trafficking, and theft. These figures highlight how important it is to understand the different methods of diversion, such as doctor shopping and theft, because they play a major role in how opioids enter the illicit market and contribute to misuse. This information is key to developing strategies to reduce opioid diversion and misuse effectively. Here we see how tolerance and dependence develop in opioid misuse over time. The chart clearly shows that while the opioid dosage steadily increases from day 1 to day 28, the subjective feeling of euphoria sharply declines. On the first day, a user experiences a full euphoric effect at a low dose. By the end of the month, the dose has increased ninefold, but the euphoria has dropped to just 10%. This happens because the brain adapts quickly to the drug, meaning the initial pleasurable effects wear off even as users take more. Many then escalate their dose or change their method of use, like switching to injection, to chase that fading high. This cycle is a key sign of opioid misuse and leads to physical dependence. Interestingly, some individuals, known as chippers, misuse opioids occasionally without developing this tolerance or dependence. But for most, increased use becomes necessary to avoid withdrawal and maintain the effects, which is what we see reflected here. Understanding this rapid escalation and loss of euphoria is crucial. It explains why opioid addiction is so challenging to treat and highlights the need to address both the physical and behavioral aspects of misuse. Opioid misuse carries serious health risks, starting with overdose and respiratory failure. The respiratory depression caused by opioids can severely slow or stop breathing, often leading to fatal outcomes. This makes overdose the most immediate and life-threatening complication. Next, when opioids are injected, there's a high risk of infections like endocarditis and abscesses. These infections result from unsafe injection practices and contaminated substances, causing significant tissue damage and potentially life-threatening conditions. Chronic misuse also affects the brain, causing changes in brain matter and cognitive impairments. It can increase the likelihood of psychiatric disorders, which complicates recovery and overall mental health. Finally, Opioid misuse elevates risks to the heart, including dangerous arrhythmias and even sudden cardiac death. These cardiac complications contribute significantly to early mortality in individuals misusing opioids. The image here subtly highlights the physical toll, such as skin issues related to injection, reinforcing how deeply opioid misuse can impact health. Here, we focus on the main causes of opioid overdose, which often stem from contaminated or substitute illicit drugs, as well as high-potency opioids like fentanyl. Using multiple drugs, especially central nervous system depressants or stimulants alongside opioids, increases the risk significantly. Dosage errors also contribute to overdoses. Recognizing the symptoms quickly is crucial. Overdose signs typically include reduced consciousness or even coma, slow or stopped breathing, and pinpoint pupils. These indicators help us identify an emergency situation promptly. In response, the first step is to call emergency medical services immediately. Providing basic CPR and supporting the airway can be life-saving while waiting for help. Administering naloxone is critical, as it can reverse the effects of the overdose. But keep in mind that naloxone has a short half-life, so multiple doses might be necessary to prevent symptoms from returning. Understanding these causes, symptoms, and emergency responses is essential for both professionals and anyone who might encounter an overdose, helping to reduce fatalities and save lives. Here we have an overview of opioid use disorders as defined by the DSM-5-TR, which categorizes 5 specific conditions: opioid use disorder, opioid intoxication, withdrawal, opioid-induced mental disorders, and unspecified opioid-related disorders. To accurately assess withdrawal severity, clinicians commonly use tools like the Clinical Opiate Withdrawal Scale, the Clinical Institute Narcotic Assessment, and the SAUS-GOSSIP. These assessments are crucial in guiding treatment decisions. Additionally, there are clinical modifiers that influence diagnosis and management, such as early or sustained remission, opioid maintenance therapy, and whether the individual is in a controlled environment. When it comes to treatment, medication-assisted therapies combined with harm reduction strategies play a key role in supporting recovery and minimizing risk. This comprehensive approach ensures that care is tailored to the individual's specific needs. This chart illustrates the different contributors to the widespread harms caused by the opioid epidemic. As you can see, overdose deaths make up the largest portion, accounting for half of the impact. This alarming figure highlights the urgent need for effective overdose prevention and intervention strategies. Chronic morbidity, which includes long-term health complications from opioid use, represents 35%. These ongoing health issues place a significant burden not only on individuals, but also on healthcare systems. The remaining 15% comes from infectious complications, often stemming from unsafe drug use practices, which further strain public health resources. Together, these factors show just how complex the epidemic is, affecting lives through immediate and lasting consequences. Addressing this crisis effectively requires a combination of harm reduction efforts, like providing naloxone and clean syringes, alongside policy reforms to improve access to proper pain management while reducing opportunities for misuse. The economic and social toll is vast, and our response must be equally comprehensive and compassionate. Here are the key takeaways from our discussion. First, opioids continue to be essential for managing severe acute pain and certain palliative conditions, but they must be dosed carefully and monitored closely to ensure patient safety. However, we cannot overlook the serious risks involved. Tolerance, dependence, and the potential for overdose are significant concerns, especially with fentanyl and substances that are often mixed with it. This makes cautious and informed prescribing absolutely critical. Moving forward, the best approach involves using multimodal pain management techniques, exploring alternatives like peripheral opioid antagonists, and expanding access to both treatment options and harm reduction services. By balancing clinical benefits with safety and improved access, we can better support patients and address the complexities of the opioid crisis. As we wrap up, I want to open the floor for questions and discussion around 2 critical areas. First, the clinical balance. How can we effectively manage pain relief while minimizing the risk of overdose in our practice? This is a complex issue, and it's important to think about integrating non-opioid adjunct therapies and carefully monitoring patients. Second, on the treatment and policy front, what system changes might help us reduce medication diversion and simultaneously improve access to effective treatments? This involves considering policy reforms as well as practical steps to support patients better. The image here reflects the importance of community and shared dialogue in tackling these challenges. I encourage you to share your thoughts, experiences, and questions as we explore these topics together and consider future directions for research and practice.